Hi, and welcome to another episode of discussions during Tinnitus Awareness Week with the American Tinnitus Association. My name is Patrick Lynch, the CEO of the American Tinnitus Association, and today we're going to be talking about some of the deeper aspects of research when it comes to tinnitus. What's next? What's needed? Where can we go? And we're lucky to have with us here on the screen two grant recipients of ATA seed grants, volunteers to the scientific advisory committee that reviews the grants the ATA eventually funds for research, and really pioneers in the field of tinnitus research. Please join me in welcoming Professor Christopher Cederroth and Professor Lopez-Escamez. Gentlemen, welcome and good to see you again.
Hello, Patrick. Thanks a lot for the invitation.
Oh, thanks for your time, guys.
Yeah.
Love having you here, and we're joining across time zones, so hopefully the tech keeps up with us here today. But as we're celebrating Tinnitus Awareness Week, so we're doing our best to highlight all the different areas kind of where the ATA intersects in between research, provider care, and patient care and provider education. And you guys obviously came top of mind for a number of reasons. We were lucky enough to have both of you write featured articles in our most recent Tinnitus Today magazine. For people who are donors or members of the ATA, they receive these articles throughout the year. And we thought it'd be great to have you come on and talk with us a little bit about genetic research in particular. Perhaps, I guess the best way to start is hear a little bit about how the two of you came to be working together in the first place. What drew you to work together? How do your expertise complement what it is you do? And how do your skill sets enhance the research that you're working on these days?
Antonio, you want to answer?
No, you can start if you want.
Yeah.
How the beginning of the history.
Yeah, it's very nice to think back about these things. That was 12 years ago, 2014, and Antonio and I met at the kickoff meeting of the TINNET consortium that was funded by Cost Action in Europe, which is only a networking funding project. So people met. We were a lot of people. I think more than 23 countries were involved in there, with 2 representatives per country, and we had 5 working groups. And during this kickoff, there was a working group on genetics, and I thought, wow, this is nice, this is interesting, I would like to join this. Especially my background, I'm a biologist, and I was entering the arena of working with humans. I was very naive to all of these things, and for me, the genetics was a bridge between the animal work and the human stuff. And there, Antonio was chair, and we decided to start building up some of the basics and the fundamentals in it. Yeah, 2014, that's how we met.
Yeah. So I think that was really, by that time, if you were telling to the people that tinnitus may have a genetic component, probably most people would never accept that idea, because the evidence by then was very limited. That's why we need to start from the beginning. And Christopher has made really very great job in Sweden, because he has access to the twin score. And this is how we were able to put together, I think that really a very relevant study, trying to demonstrate that twins has a higher heritability. And this is the beginning. If you not demonstrate that there is heritability in a specific condition, there's no sense to make genetic studies. So has to be the beginning of any kind of genetic research. It has a strong epidemiological data supporting heritability. And that's how the research makes sense.
Chris, your background, it spans biology, basic neuroscience. You guys are already talking about genetics, which I have a million questions about how that could relate to tinnitus and where we're headed. But with biology, neuroscience, clinical translation, clinical trial management, you yourself have also lived with tinnitus for a long time. You've spoken about that publicly for over 2 decades, if I'm not mistaken. How does that background in all those different areas apply to your approach to researching tinnitus specifically?
It's a good question, but I think the history is complicated because at each moment and time point of the research activity, there's been another reason behind that. I guess it was during my master's degree, and I went in France. I was passionate about auditory disorders, and I was interested in tinnitus. I already had it. And I was working in Montpellier, where they had a rat model where they could ask the rat if they had tinnitus or not, and they could use a drug to block some specific receptors in the cochlea, and they could witness the abolition of tinnitus there. And I thought, wow, this is great. This is great, but it's in rats. Maybe I could learn how to do some animal work in mice, which are more prone to genetic manipulations, and then potentially come back and work in the tinnitus area. So I went to do a PhD in a different field, completely different. That was endocrinology, metabolism, reproduction. And I guess this helped me to get another unbiased view about the situation. And I came in afterwards for my postdoc, building up a mouse model for tinnitus. And then what happened is that there was so much skepticism about, oh, we don't trust that you can measure tinnitus in an animal. We don't trust, we don't believe in what you pretend to observe. It's probably something else. And that was a bit frustrating because other areas of neurology where you can work on schizophrenia and other problems like that, people have been doing research for 40 years without necessarily being questioned. So at that time, I said, okay, if you don't believe in my animal model, then I will work back on humans, try to demonstrate my approach is good, and then what we call is a back translation to the animal models and demonstrate that what I was witnessing was potentially quite accurately tinnitus. And so there are two approaches for this, and one is to develop an objective measure for tinnitus, which is one aspect I've been developing in my research. And the other one is the genetics, because once you find potentially a mutation in humans, it's good to try to validate it in the animal models so you can then understand what perturbations you have neurologically at the molecular level, and you can start understanding the fundamental basis of the disorder. So that has been my kind of route in there. So in 2014, when I met Antonio, that's when I was facing struggles in the preclinical work and getting funding for this type of experiments. And I started to think about expanding more into humans and to make the bridge between animal work and human assessments. That's how I came into it.
Fascinating. Thanks for sharing. And Antonio, a similar question for you. You focus on severe tinnitus genetics and clinical populations like Meniere's patients. So I guess from your angle as a physician, as a professor, and a researcher, why tinnitus? What makes severe tinnitus particularly important from a genetic standpoint?
So this is really a strategy that we have to follow with most of the disease, because in fact, most of the disease are very variable. We cannot see that the patient has the same symptoms. Symptoms change a lot from patients to patients. We are using current diagnosis as umbrella term. What is tinnitus? Tinnitus shows a large variability. In genetics, there's a strategy that is to select the extreme phenotype. So if we consider that we can have patients with very mild tinnitus to very severe tinnitus, we are expecting that selecting one extreme of the distribution, we are going to find a burden of rare variation. Our genetic study has been mainly dedicated to identify rare variation. Rare variation are present in very small number of patients, but they have a very strong effect on the phenotype. That's why we think that this is very important, because once you identify one of those genes, you are probably able to do some kind of manipulation and you are able to demonstrate a biological effect on that. And the same approach we did with Meniere's is also a very large and heterogeneous condition, but we concentrated on families because this is a way to reduce the variability in the symptoms. So we select family, we do exome sequencing in the study, and this is how we were identify the first genes of Meniere's disease. So it's a question of very clear definition of the phenotype that we call of the symptoms, because that's a large variability. Without useful definition of the phenotype, we cannot really do a genetic approach.
You touch on something that's pretty important here, and forgive my layman's understanding of as we dive deeper into your gentleman's research. But for the audience's sake, we're going to probably be talking about a couple of different terms here over the next few minutes. For example, as I came into the ATA, I learned when you say something like severe tinnitus or hyperacusis or sound hypersensitivity disorders, all of these words actually have very specific understandings, and they're important for the context of when we look at research. So I guess for either of you, maybe you could help us understand a little bit some of these definitions as we start talking a little further about your work. And maybe we could start with severe tinnitus. When we say that, severe tinnitus, what does that mean? How can severe tinnitus be measured?
That can be very easily measured using some psychometric tools that we have. So this is really a questionnaire, all the patient has to say, and we are measuring the impact of the tinnitus in daily activities. And these questionnaires are already very standardized, so it's available anywhere in the world. And currently for tinnitus, like the most used questionnaire is the tinnitus handicap inventory. And we use this to identify patients that are really across this phenotype. This is just one example. So hyperacusis is a different thing. Hyperacusis is the low tolerance to environmental noise for some people. And we know that many of the patients with tinnitus also cannot tolerate this noisy environment that most people can tolerate. And many of these patients with tinnitus has also hyperacusis. And this is a study that the Christopher's also was done, a clinical study.
Yes, in fact, when we started together with Antonio, we noticed that there were very few databases where those descriptions were existing. So we started in Sweden to recruit participants from the general population and to try to characterize them with different tools. So we had one of our first working group meetings was to say, how can we have a comprehensive measure of tinnitus? And there we started deciding to use the THI, the TFI, but also tinnitus functional index, which is another one designed in the US, tinnitus catastrophizing scale, and the fear of tinnitus, which have been used by Rilana Sima in the Lancet paper on CBT. But then also we thought important to include measures of stress, anxiety, and depression, which are found to be highly correlated with tinnitus distress. Hyperacusis is then another one, and then the quality of life. So we noticed that even in this kind of global pattern of assessments, there can be a lot of differences between patients' experience. You can have patients with very loud tinnitus, but that are not bothered by it. It doesn't impact their life. And reversely, you have people that have less loud tinnitus, but then the stress is immense, but it's coinciding with a lot of stress, anxiety, and depression. So we started seeing a global picture that tinnitus evaluated by maybe a single questionnaire is informative, but to capture the majority of the coinciding comorbidities was important to assess as well.
Thank you. Yeah, and I guess just to simplify it even further down, because I've heard some debate on this one, how would either of you describe the definition of the word tinnitus itself before we even get into severe tinnitus or hyperacusis tinnitus disorder? How would either of you describe tinnitus itself clinically? Does that matter from tinnitus disorder?
It's very interesting what you say. I'll let Antonio answer that question because he's a clinician. But from my point of view, as someone that has been analyzing clinical data, I can see that not all of those that have been diagnosed with tinnitus by a clinician have severe tinnitus. And that's because some people can come, like I was me maybe in my early times during my band playing. I had tinnitus over a night or after a concert. I was going to the physician and asking, I have this buzz, what's going on? And he says, "Might go away." And I was going home, and then indeed, after 24 hours, this buzz was gone. And I never came back. From a medical point of view, you still get a tag in the medical registry system. You get this H code from the WHO 93.1 that says you've had tinnitus. But then, was it bothersome at that time? No, I came in with curiosity to understand more about what this was. I sometimes compare the problem with tinnitus and its definition with the one with blood pressure in comparison to hypertension, right? You need several measures of blood pressure at different time points to finally being diagnosed with hypertension. High blood pressure alone once doesn't say you're hypertensive. The same way, if I go once to a clinical doctor to inquire about tinnitus doesn't mean I've got constant, chronic, severe, bothersome, impacting tinnitus. Maybe Antonio can give more details how this is done in the clinic.
So yes, one thing is tinnitus as a symptom. Anybody can experience sometimes the perception that you have a noise that is not the real noise. You have something that happens for seconds or minutes. Everybody can experience that. But however, when tinnitus is considered a disorder, is when you have a problem, when the patient is suffering, saying in easy words. And we are considering severe tinnitus as a proxy of a tinnitus disorder, so you can see. So that's why we trying to make things very easy for the doctors, and just using a questionnaire, we can consider if a given patient has very high scores in this questionnaire, probably we have to take time for that particular patient because he's suffering. That's the main point, just to make things very easy. But of course, we have to do audiological studies to identify something that is very common. If a patient complains about tinnitus, we have to do a hearing test. That's very clear because we know already that there is a strong association between hearing loss, tinnitus, hyperacusis, as we have explained. So that's required. We try to see what are the needs of the patients using these questionnaires.
Yeah, primary tinnitus is also a terminology that could be thought about because people with hearing loss can come for an assessment at the ENT clinic and they would be asked the question, oh, do you have also tinnitus? Oh, what is this? Oh, that's a ringing. Oh, yeah, I do perceive it. Okay. And they get also this tag, although it is not impacting on their life quality. So there isn't yet a good way in the WHO coding system to say, I've got a primary tinnitus complaint. This is dominating any other aspect of the audiological procedures I have. This is my major problem. Hearing loss or hearing problems come second. So there also we need a better stratification on how to say the tinnitus that you come to complain for is the one dominating the impact on your life quality and not the reverse, not asymptomatic of a dominating hearing loss condition, for instance. So that I think is going to be needed in the future. But the work that Antonio has been starting to do with the genetics is a very good path towards this, because once you want to stratify people into different classifications, you need biomarkers. And this is where genetic biomarkers, you cannot oppose yourself to that proof. It's very objective.
I think that was one of the things that was most surprising to me as a patient who's had tinnitus for over 20 years. The idea that the importance of these biomarkers, which we'll get into from a patient perspective, that's not something I'd had heard from a doctor or physician before, that we didn't even have some of these objective biomarkers that you would think we might have, which obviously is at the core of both of your work. When we talk about genetics, and maybe this is a good chance to talk about each of your articles that were in the most recent issue of Tinnitus Today. Chris, your work focuses on families and tinnitus, heritability, if I'm pronouncing that correctly. Your twin studies showed bilateral tinnitus is 68% heritable in men, 62% in women. Many folks thought that was higher than they expected. I guess before I ask you any other questions, am I saying it correctly? Is it heritable? And what does that actually mean for someone who has a family history of tinnitus?
Yeah, so that first study performed in tweens, everybody agrees that tween studies can inflate the numbers that you have there. But I think that the good aspect of it is that you can statistically test whether the genetic component dominates over the environment. So what you're assessing in heritability is how much weight you have in the genetic contribution to a disorder, how much weight you have from the environment, and you try to assess that. So 68% of genetics, which was significant, was dominating over the environmental aspects. And then we had unilateral tinnitus was down to 28%, which means the environmental impact was more profound for unilateral tinnitus than the genetics one. Now, if you go into proper measuring genetics and biomarkers, that the prevalence of these impacts is much less. But that's another story. So the other way we went to try to demonstrate that there was a transmission within a family was to go for adoption. So adoptees, that's very interesting because you can In Sweden, at least, that was the magic of it. So we had access to the whole population of Sweden, which is 8 million people. In there, you could identify about 10,000 adoptive children whom you could link to adoptive parents and link also to biological parents. And using medical registry data, you could identify who's been diagnosed with tinnitus at a hospital. And with this, we could demonstrate that if an adoptive parent has tinnitus, the likelihood for the child to get tinnitus was not greater than one, so the odds was null. But if you have a biological parent that has tinnitus, then the odds, the chances for the child to get tinnitus were 2 times higher and significant. That means it's running within the family. Now that heritability score was a bit lower, but that is also because when you're looking at the history of how tinnitus has been diagnosed in a clinical setting, the way it was done 20, 40 years ago was not equally well performed as it is done now. So maybe at that time, people didn't really care about the truth or the complaint of the patients. And maybe now in the current era, there's much more awareness from clinicians on how to tag and how to properly make that assessment. So there is a difference in the generation, how the diagnosis was performed 40 years ago versus now, and this can account for the lower scores we got. So the third approach we used with Antonio was to perform a familial aggregation. So we recruited those participants in Sweden, and we asked them how many siblings do they have, and how many of these siblings had tinnitus too. And there you could see that eventually the odds for one of the siblings to get constant tinnitus was 2 times higher if the proband had tinnitus as well. But if it had severe tinnitus, then the odds were raising up to 8-fold. So then depending on whether you have bilateral tinnitus or severe tinnitus, that also impacts on the likelihood to have it shared within the family. This is where we understood, Antonio and I, that severe tinnitus is the most transmitted trait within the family among all different tinnituses that we could assess at that time. And that's how we reason on his strategy to go for more extreme phenotypes and to focus on those that have a more bothersome condition. And in fact, thinking about it, the likelihood that we found for severe tinnitus in the families, that's the same likelihood you get for schizophrenia. But
Well,
nobody really knows about it because nobody asks the question to someone that comes in the clinic, do you have other people in the family that also have severe tinnitus? Everybody believes it's a symptom, so we don't care about it. But if you start asking the questions about severity and about whether the family has history of tinnitus, maybe this will come as a new kind of indication that it's a disorder that's been there, in fact. Yeah, there's a lot to learn from this. Yeah.
Was that surprising to you? Coincidentally, I'm an adoptee myself. And so my family and I joke quite often about nature versus nurture and which parts of my personality were whose fault and when. But when it comes to these genetic findings, and you touched on this, they were more likely to have been found in bilateral and severe tinnitus. Does that mean that if I don't have severe tinnitus, or if I have occasional tinnitus, it could potentially have a different origin other than heritage?
That's interesting because we've been performing large GWAS analysis in parallel to the work that we were doing with Antonio. And genome-wide association is different. And Antonio maybe is going to describe what he has been doing with the sequencing. When you have genome-wide, you look for variations that are quite common in the population, but not as impactful. But it's the sum of those variations that accumulate into a phenotype. And when we did the first study on hearing loss, we were able to find many of common variations that can accumulate into hearing problems. When we did that work with tinnitus, which was poor tinnitus definitions, it's occasional tinnitus, it's tinnitus, have you ever heard it once in your lifetime for more than 5 minutes? So it's not severe at all. We found no signals. So this is why now we need a proof for this. But my interpretation is that the occasional tinnitus you have is asymptomatic. And once it's becoming constant and it's not bothering, it's also symptomatic. But the severity, that's another scale. And this is where the genetics hops in with rare variations that make your tinnitus much more bothersome and impactful on you.
Maybe that's a good opportunity to ask you, Antonio, a little more specifically about your work and gene identification in particular. You've identified ANK2, aka P9, TSC2, as consistently being associated with severe tinnitus, which we defined a little earlier. What do those genes do, if I'm even pronouncing them correctly?
Yeah. So I would like to say that something that we were expecting. We can say that ANG2 is closely related to the formation of synapses and prolongation of the axon. So the extension of the connections of the neuron is changing. We already know that this rare variation can modify the morphology of the neurons. And this is something that we were already have in mind. The main thing of this study is that we were able to make a discovery core using very small number of patients that had Meniere's disease and tinnitus. We were able to replicate the findings in a Swedish core that they don't have any Meniere's. So that's what really important. But they also have tinnitus and severe tinnitus. And this was not by chance because we use also a third core of individuals with epilepsy, and they don't have this enrichment of rare variation. To say it's not a specific mutation that we found, it's a set of rare variation that if you look to each of them, they may have severe effect on one particular individual, but another individual with severe tinnitus has not exactly the same mutation, has a second mutation in the same gene. So ANG2 is related to the formation of synapses, as I explained. AKP9 is a gene that has been already associated with some cardiac disease, or some type of arrhythmia. So we really don't know what it's doing in the central nervous system, but also some rare variation in AKP9 has been linked to dementia in African population. This studies has to be validated and replicated, but this is starting to show some of the link that we already think that there is between cognitive impairment, so people that are losing the memory, and tinnitus. And this is one of the areas that we are really very interested because there may be some common mechanism linking some type of rare variation, rare mutation in tinnitus with cognition issues. And we already know that severe tinnitus, one of the clinical manifestations that may have is also cognitive impairment. So cognitive decline can be observed in patients with severe tinnitus. The data that we have now is that in, let's say, young adult, that is about 50 years old, 25% of these patients has some kind of cognitive impairment. I'm talking about patients with tinnitus in the 50s. So this is something that we have. It's a very mild cognitive impairment, but we really need to follow this type of patients. And we really don't know about TC2, what it's doing, because we have to do much functional.
Antonio, some of these genes that you're talking about, they're in the, if I understand this correctly, they're expressed in the limbic brain regions, which, again, oversimplification, but predominantly are related to emotion and attention, not necessarily in auditory pathways themselves. Is that telling us anything about tinnitus?
Yes, because I think that if you think that the genes that we are targeting are related to severe tinnitus, that means that there is an emotional component in these patients, in many of them. So it could be an emotional, that could be a cognitive issue, and this is the link that we are trying to establish with cognition and severe tinnitus. We don't say that any kind of tinnitus can be associated with that, but this is additional symptoms that some of the patients we have, and this is the way we try to identify that tinnitus is not only related to molecular changes in the auditory pathway. Tinnitus is involving also different brain areas, and the limbic region is one of them.
And on top of that, not only is the limbic region very important, but you even found genetic data showing that tinnitus signals are different from hearing loss signals. So often in my daily work, I hear from folks who say, I can't hear, that means I'm going to get tinnitus, or they seem to conflate the two things, hearing loss with tinnitus. But some of your work has shown on the genetic level that there is a distinction between tinnitus signals and hearing loss signals.
Yeah, there are different signals for hearing loss genes, not only common variants, but also variant. This is something that is important to understand. There are signals that can be shared for tinnitus and hearing loss, and there are a specific signal for hearing loss and a specific signal for tinnitus. That's why the understanding of the molecular structure can be complex, and that's why we are trying to look in some studies like the wide association study for common variants, that, as Christopher has explained before, this common variant has a small effect on the phenotype, a small effect on the symptom. Rare variant has a large effect on the phenotype. Common variants are found in a lot of patients. That could be important, but you need the additive effect of multiple common variants to explain the phenotype. However, a single rare variant can explain the phenotype in a particular individual. That's the main thing that we try to do. But also there are some variants that can have influence, both of them, hearing loss and tinnitus. And this is something that happens also with the common variants, and something that we really need to have a much better definition of the different patients to be able to split the effect of each of type of variant.
But it sounds like we're already starting to see some common denominators here and links between one genome and another, or one symptom and another. And maybe this is a good chance to talk a little bit about where some of your work overlaps and the link between hyperacusis and tinnitus. Chris, you had a 2020 study that found 80% of people with severe tinnitus also have hyperacusis. That sounds high. Were you expecting it to be
No.
that high or that tight?
Yeah. So the way we started doing this analysis in our cohort in Sweden was to gather a mass amount of data that's quite comprehensive, and then to start selecting a few things. And we started focusing on TMJ disorders, so temporomandibular joint disorders, headaches, and hyperacusis, which were three comorbidities that had been evaluated by other colleagues from the Tinnitus Research Initiative and Bertolt Langut in Regensburg in Germany, where he found in a clinical population that this prevalence was quite high. But he never had a control population to evaluate the odds of developing a condition. So with our Swedish study, we had the advantage of having non-tinnitus controls, and then to check if you have prevalence of TMJ or headache, is it really higher incidence in people with tinnitus? And the numbers were a bit low, odds ratios around 3, 4. It was not dramatic. But then when we started investigating hyperacusis, then the numbers went way higher. And we started also stratifying things differently. If you have any tinnitus definition, whatever, how you formulate it, like to resemble what has been available in the scientific literature. But if you have severe self-reported tinnitus, or whether you have severe tinnitus according to the THI scores. And the ones with severe reported or the THI scores being severe, the odds ratio was outstandingly high, but to such a level that I'm wondering, if you're investigating severe tinnitus with neuroimaging or even the genetics, how can you be sure you're not measuring something else that could be hyperacusis? They're going really hand in hand. So it's creating a lot of doubt on some past research, because maybe past research hasn't defined whether they're working with a population that has severe tinnitus. They're just measuring patients with tinnitus. You don't know if it's constant, if it's chronic. All these differences won't allow you to define precisely the type of patients they're working in. And not all patients from different countries would have the same type of burden. There's been studies from Deb Hall showing that in Eastern Europe, the prevalence of severe tinnitus is twice that of what is found in West Europe. So even definitions according to clinical reports might differ there. So it is very important to consider hyperacusis in future research, definitely. But it's going to be very difficult, because likely you're going to ask the question, how do you define hyperacusis? How do you segregate this? It's not easy.
In practical terms, Antonio, this odds ratio can reach 77.4 for severe hyperacusis plus severe tinnitus. Practically speaking, what does that mean if I'm someone who's experiencing both of those conditions?
So this is really a very extreme phenotype patients. A patient that has a very severe tinnitus, very severe hyperacusis is very rare to find that. But I fully agree with the comment of Christopher that we have to include the measurement of hyperacoustics in any study of tinnitus, because that would be probably the only way that we can distinguish the patients that have severe tinnitus without or with a mild, very mild hyperacusis against the patient that have mainly complaint is hyperacusis, and they really don't have some of the things with severe tinnitus. And I think that once we have a core like that, we can probably use the rare variant analysis approach and probably try to find some specific genes that could be targeting severe tinnitus and targeting specific severe hyperacusis. And that would be a potential approach. But I think that, again, the better phenotype information, and particularly how to measure hyperacusis, that is not systematically measuring our clinical studies.
The occurrence, sorry, Patrick, the
Yeah.
occurrence of hyperacusis in absence of tinnitus, even mild, this is very rare too. So those genetic designs and study designs that Antonio is proposing, it's going to be very hard to perform because even in a clinical setting, the diagnosis of hyperacusis is very badly done. We've been relying on some of medical registry data that contains genetic analysis, and we see it's completely unreliable because even definition by the WHO is not clear. So the future for performing that work is going to be requiring a strong coordination between patient associations, I would say like ATA, but also hyperacusis research, where there is also increased awareness about how to implement that type of medical diagnosis into the clinical settings. It'll be indispensable.
You make a good point because so many patients are reporting to their physicians both of these conditions, tinnitus and sound sensitivity. And so if I come into my doctor and I say I have both of those things, what should we could start with the patient, since so many patients are probably watching this. What should they know about this relationship between tinnitus and then sound sensitivity? Are they completely separate conditions? How should that inform treatment discussions?
One of the things I think that we really need to clarify is that hyperacusis is probably an umbrella term, and some other entities are or can be considered as endophenotype of hyperacusis. I'm thinking about noxiacusis, which is patients that experience pain in the ear, not pain in the head. I'm thinking about also phonophobia, which is a symptom commonly found in migraine patients. And these patients also develop avoidance behavior. And this is clearly different from misophonia, where you experience something that is a specific type of rhythm sound that triggers your intolerance to noise. And this is completely different. The majority of the patient has a loudness hyperacusis, so they cannot tolerate loud sound. One of the easy things to start with will be to clearly define which subtype of hyperacusis a patient have. Because if we can have clean data in terms of understanding, we can probably do a better genetic approach. And we will probably reduce the number of samples, but we have better clinical definition. That's the essential step for that.
Hearing difficulty, understanding speech and noise, it strongly confounds both of these conditions. How do you disentangle like which thing is causing what for the patient or for the provider?
It's very difficult. It's very difficult because we notice that when you perform an audiogram based on pure tone audiometry, you can have individuals that have excellent hearing. They can hear tones, beep, at perfect levels, but then they would be tested for speech understanding in noisy environments, and then this is not equally good. And I think there, the complication also is that speech and noise tests are not yet optimal in detecting subtle effects, unless that's right. If you have profound problems in understanding speech, then it could be sensitive for that. But for individuals that have tinnitus, where this could be impacted, the people that would have a test in non-noise environment would probably detect some good scores in the words. The way I can hear you quite well now in an environment that is devoid of background noise information. But you put me in a restaurant environment with some echoing and some problems with reflections and glings and glasses that go there, I will be completely incapable of understanding you. The tests that are currently available in the clinic don't have that resolution. You go from one country to another, and then also the test will change because maybe the word recognition in Swedish will be different from the word recognition used in Germany and the one used in Spain or in China. So you cannot compare country from country with these things. They're not really good objective measures. People are trying now to use other methods, which is the frequency envelope response, and potentially that could be better tests to quantify objectively the ability to understand or to detect vocals and consonants in a noise environment. But this has to be developed. So currently, when you're asking how we can disentangle everything, we're not there yet. And there's more work needed for separating the two. I don't know if you agree, Antonio.
Fully agree with that. Particularly something that is still pending standardization is high frequency hearing loss to explore the frequencies beyond 8 kilohertz, and the speech in noise test has to be standardized. That should be part of the assessment of the patients with tinnitus, and probably we have more reliable information to identify subgroup of patients.
You guys both are touching on where we're headed next, which is the fact that there's no shortage of work to be done. There's always so much more we need, whether it's a better definitions in data, better ways of getting information from patients themselves. And that's, of course, where organizations like the ATA come in, right? We're a nonprofit here in the US that's been around for 55 years now, as we're celebrating Tinnitus Awareness Week, and there's still so much work left to be done. One of the points of doing these kinds of talks this week is to raise awareness, literally, about the work we're doing as a nonprofit, but the work that people who are watching this can also do with us. Last year in 2024, or 2 years ago now, gosh, in 2024, the ATA awarded separate grants to each of you. For Antonio, it was to support your research in molecular genetics and epigenetics of severe tinnitus. Chris, for you, it was a grant to further investigate this objective diagnosis of tinnitus, which we talked about earlier, the biomarkers. For folks who are potentially thinking about applying for a grant this year, we just announced that our call for grants are up this week. For either of you, as a seed grant funder trying to advance scientific understanding of tinnitus and patient care, could you share a little bit about how even that little bit of support matters for the work that you're doing?
Antonio, you want to start?
So the current project that we're trying to get is trying to analyze the data and trying to establish a link for us, between tinnitus, severe tinnitus particularly, and cognition. And we have been able to use the Unity core, which is a large European study that gives some relevant data in the clinical trial for doing that. But my plan is to put a large grant, to be able to measure at the same time genetic and epigenetic data, and that has to be a very large grant, because we need to follow up these patients and to see how epigenetic changes are measured over time. So that would be like the goal, and this is something that I cannot do alone. We probably need a multi-center studies to recruit patients and to follow for a number of years. But that will give probably a more complete information about what are the environmental factors that are acting on patients with tinnitus to develop a more severe or not to develop more severe tinnitus. And probably there will be the way to generate biomarkers that we can use as a predictive value about the outcome of tinnitus. That would be what I would like to do.
Yeah, Patrick, to answer your question, the seed funding from the ATA is simply indispensable. Thanks to that, we were allowed to acquire some preliminary data that got us into acquiring a larger funding from Brainwater Charitable Foundation, which now we're performing as well. It complements the funding from ATA, and we're validating our approach on a larger consortium level with 6 other clinical sites that are testing this method that we've been designing. So it really kicks in, it helps, it favors. Now, I would say maybe I'm always, maybe also as a tinnitus sufferer, seeing the dark side of the moon. And I've always hoped that governments will have financing some of these aspects also and pushed further. It has been terribly hard to get governmental funding in Sweden, in Germany for these types of things. I've been very lucky that we managed to get into consortiums with Antonio that were the consequences of the initial networking grant that where we met together, this TINNET. We got some kind of grant that funds the education of PhD students that helped us performing the genetic studies and analysis. And then we had this Unity project, which is a clinical trial just recently published in Nature Communications, a very hard work that came out there, and that was EU level funding. But still, we have limitations at the national level, and I'm really asking myself why there's this limitation. NIH has had an NIDCD grant apart thanks to patient advocacy, and that mobilized a lot of funding and the creation of a deafness and communication disorders branch of the NIH. Yet the funding for tinnitus research in there is not increasing. I would say any support that comes from ADA is necessary, but I don't know, as a researcher, as a patient, and I'm not a politician, so unfortunately I wonder how I could do this, but how to start increasing that governmental awareness that it requires part of the funding. It's not asymptomatic that we're working on, it's the disorder. We want to focus on the thing that impacts people. So we're studying something that has a major societal impact. And please help us. Yeah.
Thank you for that. Yeah, none of this happens in a vacuum. It all happens together. And the more folks who are talking about it, the more likely the government ends up hopefully being involved. So there's no doubt or there's no question that we need the government to step up if we really want to make that next leap forward. I guess as we're talking about the future, 5 years from now, what do either of you expect we might know a little bit more about tinnitus that we don't necessarily know today? And that could come from funding from small nonprofits like the ATA, it could come from the government, but where do you think we'll be 5 years from now that we don't quite have right now?
It's hard to answer that question always with predictions, but I can tell you that after being in the panels within the ATA, I was not aware Antonio got the grant because I was excluded from the panel decisions. So I'm happy he got it. But some of the some of the projects I've been witnessing in the last 2 years were not that exciting, except last year. Then suddenly something is happening. So there's been a bit of a roll down, and suddenly now something is coming in. And the way this is coming in is because people from other niche areas are jumping into it. The same way Antonio, who's been working with Meniere's disease, suddenly he went out of his comfort zone and went into tinnitus. Maybe the same way I've been working on reproduction, and then I expanded to tinnitus as well, but coming from a different angle. And I think we're coming now at a stage where people have acquired a lot of knowledge in the auditory system and hearing, and there are interests about what is modulating this plasticity in the brain at the animal level, but also in the human level. There's been a big difference the way America and Europe has been working on the two things. The United States has been very competitive in the preclinical domain, so a lot of animal work. Europe has been a bit more resistant into it, maybe because of legislations in animal training, animal behavior, and has been much more active in the clinical arena. But this is now getting equalized in different levels. And this is very good news. So I think maybe in 5 years from now, there will be clearly a better understanding of what is disrupting the mechanisms happening either in humans or in animals in the brain where a severe tinnitus is present. Maybe there's going to be much better distinction between hyperacusis phenomenons and tinnitus themselves, getting a true signal that can separate the two. And this will, along with the progress that is ongoing with clinical trials that we have now, more studies and randomized clinical trials that have been performed that's coming in the news, showing that it's becoming exciting to perform that research. Even if we're using questionnaires to measure tinnitus distress, that increment in knowledge is going to help pushing the rest forward. That's why also I'm very much interested in clinical trial management, because it's going to be the next step. So I'm gently moving away from the animals into action, more active work with the patients themselves.
Antonio, what do you think in the next 5 years? What do you think we'll be seeing that we don't quite see today?
My view is that human genomics is going to define the way that we have to manage patients. I think that we are in the process that all patients with tinnitus need a hearing test, and all patients with tinnitus will need a screening for cognition, because probably if we are able to anticipate the development of cognitive decline in 10 years, we are going to have biomarkers to predict that. And this is the only way to do that is going to go through whole genome sequencing data set to do the analysis of structural variant. That is something that nobody is currently doing for most of the rare genetic disease. People concentrate on small point mutation, and I think that we have a lot of information. And this can be used as a protective for severe forms of tinnitus, probably in the very early stage. So this is that will probably dominate the future.
The future is right around the corner. You're mentioning so many topics. I wish we had more time to cover, but I want to be respectful of your time. And I want to thank the audience. If you're still watching, you clearly have a deep interest in where we're headed in terms of research, in terms of genetics in particular. We're so thankful for you guys for spending your time today. And we're proud to call you grant recipients of the ATA. Let me ask either of you, if you made it this far as a patient and you're still watching this video wanting to learn more or wanting to get involved, should someone consider maybe getting involved, volunteering, or donating to an organization like the ATA? Do these grants help, and how can I, as a layperson, try to move the needle forward?
Oh, I would say, yeah, communicating about how bothersome this condition is the first thing. And maybe at some point in time, those collisions, I view them maybe exponentially, they will reach out to maybe a member of the Senate, a member of the NIH, or someone that is also affected but sees that there are no options, that has a lot of money. There is now, I'd say, curiously, a larger proportion of the population that is multimillionaire. They have no good options from a tax purposes than to give it away to charities. And maybe these people will say, okay, now it's time to do it for tinnitus. I think the history of the ATA being in that arena for such a long time is very good. So they can be trustful that it's going to be used in a very good way. And this is going to help certainly advancing the science further, much for sure.
All right, gentlemen, thank you both for your time and for your hard work. We're proud to have been a small part of some of the things you're doing. If you're still watching and want to know how you can get involved or learn more, visit ata.org. Both Christopher and Antonio have contributed articles in our most recent Tinnitus Today magazine. All members of the ATA receive this magazine 3 times a year, as well as digital copies. But without taking any more of your time, we've already taken so much of it. I just want to say, on behalf of the 50 million Americans we represent here in the U.S., gentlemen, thank you for what you do. It does make a difference. And I'm excited to maybe have this conversation 5 years from now and see who was the better predictor of the future. But gentlemen, thank you so much for everything.
Thank you, Patrick. Thank you, Patrick.
Thank you so much.
There is
All
a
right.
lot of hope. There is a lot of hope. I'll tell you briefly. You've seen recently the news about gene therapy for hearing loss, right?
Yes,
Right.
yes.
So that also is something exploding now. And I can really foresee, because the old genetic manipulations are going fast, if we can identify a patient that has a rare mutation in tinnitus and that there is a way to confirm this is really related to the tinnitus, I can foresee like an injection in the CSF. The little virus would travel at the brain specific area where it needs to be and correct the gene deficiency. If people have some very rare conditions, catastrophic tinnitus, these situations may allow FDA fast track approval for treatments, and possibly at some point, someone with severe catastrophic tinnitus will be treated. That I see as a real potential in the next 5 years.
You touch on something really interesting, Christopher, which has been fascinating me. If you think about it, when I was in high school in the 90s, we were so excited because we had mapped the first human genome. And that was the great breakthrough. And now here we are, not that much later, talking about the potential of getting down into the hyper definition of biomarking something like tinnitus at the genetic level, which, of course, who cares about finding the definition of that? But that is the spark that leads to what you're talking about. In cancer, we talk a lot about precision therapy. I'm a 3-time cancer survivor, right? So I had leukemia 20 years ago. The protocols today are incredibly different from what they were 20 years ago. And a lot of that is because of this precision therapy. We could take a pill or design an injection specifically for your genetic tumor. There's no reason to think that's not possible here with tinnitus.
Yeah, clearly.
Clearly, you guys are at the forefront of making that happen. So please keep it up. Let us know at the ATA what we can do for you. And if you are a member of the ATA, thank you. If you're not, please consider joining today. We cannot give what we do not have. So we were able to give grants to Chris and Antonio because of donations that have been made in the years prior. We want to continue funding the future of research, and we can't do that without your help. So thank you for being a part of our mission. Gentlemen, thank you for being part of the future and for your articles and your work and everything else. And I can't wait to talk to you guys in 5 years and see what we've found.
Happy to be there.
All right. We'll see you guys soon. Thanks so much.
Bye-bye.
Thank you. Bye.